Everyone can see the screen, yes?
Right.
Yes.
Oh, I forgot to ask you, Rehab, you know how to use the annotation tools if you desire to do so?
Yes, I found out. Yes.
Okay.
Yeah.
All right, good. Excellent.
Super. Go through, I hope to finish 2 quick presentations before we do a small exercise, and then I hope to invest more in the practical exercises. So whenever anyone has a question, please let me know, and I can stop and redo the slide or clarify whatever is unclear for any of you. So this is the first presentation on overview for research methodology. And by the end of this session, we should be able to describe the various steps of research, how to formulate appropriate research questions, and how to formulate appropriate objectives. I'm going to touch very lightly on the proper methods for data presentation and summarization. I think that Dr. Samar already gone through that. And just a small slide on research recommendations according to the results of our study. So my first question to everyone is the question that Dr. Henry has started with. What is research and why should we conduct research? And then when we answer these 2 questions, we can start answering the question, how is research conducted? So I think we've all gone through this. I just need a quick answer from any of you, please.
Hi. We do research for multiple reasons. I have trouble with using the mic. I have no idea why.
Okay.
We're doing research to benefit from it. We conduct research to serve for the community, for the sake of research, for enhancing the life of the people, and for the most important, to enhance each other's life as a researchers.
Dua, do you have anything to add?
According why we conduct research, we can have like a certain question of interest, and we need to find an answer for that question. So we conduct a research to answer it in a systematic or methodological way.
Okay, super. And anyone has anything else to add, or should I move on? Any other additions? I think we've gone through that. I think Henry has even touched on that. So very broadly and quickly, research by definition is a systematic and scientific study in order to establish new facts and reach to new conclusions. And the whole idea is to contribute to what is known as generalizable knowledge. Now, the primary purpose of research is to answer a burning question. So usually when any researcher starts their research, there is a question that has triggered that researcher to start working on that research. So in order for us to move on to how is research conducted, we should know that there are certain steps that have to be fulfilled for us to start and accomplish our research successfully. So the 4 main steps are: we have to identify our research problem, and then we have to identify the proper data collection methods that we will be using. We should address data presentation and statistical analysis. I think this was covered already. And then after that, we should interpret our findings and write a report. So our first step is to identify our research problem correctly. So in identifying our problem, there has to be a topic that triggers the researcher's attention, and there is this urge to conduct the research because the researcher feels there is a need to know more about this problem or know more about this issue, and the researcher has also gone through the literature in a way that has identified where the gaps in knowledge are. So any discipline can be a focus of our research. So it could be avian influenza, it could be child health, it could be reproductive health, it could be cancer, it could be exposures to chemical hazards, it could be anything. So for each and every one of you, I'm sure that you have started to work on your projects or started to think about them. And in doing that, you have started to consider where are the gaps in knowledge that you would like to work on. Right? Yes? Okay. Yes, super. So when we formulate a research problem, we need to find more about that, and we can have lots of sources for that. So we can have observations from our daily activities. We can read a lot of literature, something in the newspaper, a circular. We could even hear something that's formal or informal, and that would be the trigger for initiating our idea for research. So when we start formulating or focusing our research problem, there are interests. So if I'm interested in pediatrics, that's where I would be focusing. I would get some new ideas, identify the needs, I would identify the gaps in literature and information, and that's where I would focus. So depending on what we are interested in, we would go through this flow of flow chart, as they say. I'm trying to find the annotated buttons. There they are. So there we go. Okay, so we start with our interest, and then we have an idea, a new idea, and then we get to identify what are the needs and the theories that are available, and then we focus on that in order to identify our research problem and what we want to do. I want to clear this. Okay.
You have to hit the mouse button.
So, yes. Okay. There we go. Okay. Now, when we are still in our first step of problem identification, we have a clear problem, we have stated that clearly to ourselves. We need to focus on the problem justification. There are two important points that we have to consider when we justify our problem. We want to identify why the problem is important, and if we can convince others of its importance. So can anyone tell me why these 2 points are important when we are thinking about our research? Sayed?
Actually, when we should look to address the gap in the literature, and I should address a specific problem that I can answer in my research. I mean that I should look for applicable research. And sometimes we use some words like SMART to define our objectives to be specific, measurable, applicable, realistic, and timetable. So
yes, we will get to that. Yes, thank you very much. We will get to that. You're one step ahead of me, so thank you for that. Maha, can you tell us why we need to convince others of the importance of our research? It's not there.
So,
Yes.
hello. So I have
Hello.
a problem in the voice. Can you hear me clearly?
Yes. Yes.
So we have to convince others to get approval for our research. It has to have an impact to be accepted to start the research.
Okay. Super. Any other thought, Bulana? Bulana? Can you hear me, Bulana? I don't think you're with me.
Rehab, actually the voice is not clear at all. I barely hear you.
Really? Okay.
Yes.
Should I, is this better? Is this better? Can you hear me now?
Yeah, now I can hear you better.
Okay.
Rehab,
Yes.
what's all that tapping noise?
What's tapping? I don't know.
Or maybe somebody else is typing, or
I can't hear anything.
There was tapping voice, but now there's nothing.
Okay. Yeah, I was just hearing. It sounded like someone is typing. Okay, go ahead. I mean, I hear you fine.
Okay, super. I'm going to raise my voice, and if it's still very low, please let me know.
Okay, now this is fine.
Okay, so when I'm talking about problem justification, we have two issues that some of you have already stated. We have to identify the importance of the problem in order to be able to access or have the ethical approval for conducting this research. And the second point is about convincing others of it is also important in the ethical approval and for funding reasons. If we would like to fund our research, then it's very important that we have to convince our donors to put money for this research. Is everyone okay with that? Yes?
Yes.
Super. And then we need to raise a research question. And by doing that, we have here some examples. So I could state the question. It always starts with the verb, a question verb like is or what or how, depending on what you're asking, and you should formulate the problem in a question format. Now, the second, the last point.
Rehab, would you please unmute yourself?
Dr. Rehab, you're muted. We cannot hear you.
Okay, is this okay? Yes?
Yes.
Yeah, that's fine.
Okay.
Yeah, we missed a couple of slides before because you were unmuted, you were muted, so we couldn't hear anything.
Yeah, I missed them too.
Okay, I'm just saying that we should, at the end of when we have formulated our question, we should formulate a research goal and objectives. Okay, and there is a difference between goals and objectives. Goals describe the aim of the work in a very broad sense. So we need to prevent a certain disease or improve a service delivery or improve utilization. We may want to enhance the quality of life or improve the treatment protocols, whatever they are. So it's a very broad statement, whereas objectives are very specific, and El Sayed has certainly stepped ahead and gave us how we should formulate our objectives in a smart manner. And usually research objectives are divided into two types. Primary objectives, and these are objectives that we will definitely achieve by the end of our research. And secondary objectives are objectives that we may achieve on the way when we are conducting our research, but if we don't achieve them, it's okay. But primary objectives are objectives that are linked to your research question, mainly. So the objectives should be very much related to the question. They should be very specific, and they should be ordered in logical manner and sequence. They should be achievable, taking into consideration all the available resources and time that you have. And they should be really mutually exclusive, so do not repeat or overlap your objectives. Now, objectives are formulated in a way by using action-oriented verbs like to find out, to determine, to identify, to examine, to measure, to explore. So you always have these action-oriented verbs at the beginning of your objectives. And the specific objectives answer the questions of what am I doing, who's going to do them, to whom are we going to do these activities in order to get what, so what is the outcome of what we're doing, when are we doing it, where are we doing it. And to describe the type of incentives provided by pharmaceutical companies to their employees is a possible objective. We may want to find out the opinion of employees about medical facilities provided by the Ministry of Health. We may want to determine the impact of training on midwives' practice. So it depends on what we're doing, and we write down our objectives with an action verb. Now, a very important way to structure our objectives is that they have to be very smart objectives. They have to be specific. We have to be able to measure these objectives in a way. They should be measurable. We should be able to attain them, and we should be able to achieve these objectives. They should be relevant to our research, and they should be time-bound. Our specific objectives will facilitate the development of your methodology, which I will be talking a lot about today and tomorrow, and will help to orient the collection, analysis, interpretation, and utilization of our data. So specific objectives, for the last time, we want to address who, what, to whom, when, where, and what, and they should be smart in order to be very specific, measurable, attainable, relevant, and time-bound. Now, I want to tackle a last point about study hypothesis. Study hypotheses are the assumptions or suppositions of your study. So can anyone tell me what a study hypothesis is? Maha?
I think it's like the study question, the problem we want to explore or to find finding about it. So we put hypothesis between like setting a relation between two factors and to know if they are the problem is related to this reason or not.
Okay, so if can you give me an example of a research question, and then you can formulate the study hypothesis for it? Any question off the top of your head?
Yeah, maybe we can, if we study the relationship between, say, COVID infection and standard of life of subjects. So we will put hypothesis that Maybe people with low standard class will have will be more prone to infection with COVID-19.
Excellent. Thank you very much. So you are supposing, before you start your study, that the social class or the social level of the participants will affect the risk of infection with COVID-19.
Yes.
Did I understand this correctly? Yes? Yes? Maha?
Hello?
Yes?
I think
Yeah.
I'll vouch for that. Maha seems to be frozen.
Okay. So our study hypotheses are what we are supposing or assuming at the beginning of our study. So for any study, there are two hypotheses. The first hypothesis is the hypothesis that Maha has given me. So it's related to the question. It's related to why I have conducted this study. So she has started the study with an assumption that the social level of participants will affect the risk of infection with COVID. Another important hypothesis that will be tested statistically when we go into statistical analysis, if we do, is called the null hypothesis. So the study hypothesis is called the alternative hypothesis, and the null hypothesis is the hypothesis where we assume that what we are supposing is actually not true, and we want to find out if it's true or not by conducting this research. So for any study, there are two hypotheses. The null hypothesis that supposes that there is no relationship between variables that we are studying, and the alternative hypothesis, the hypothesis that is linked to the research question that we are trying to achieve. This is very important for any study that has an analytic component where we will find associations between our various variables within the study. So, first step is done. We have identified our problem. We have stated our hypothesis and our research study question. And then the research pathway. Now, step 2 is about proper data collection. In order for proper data collection to be achieved, we have to address several points. The first point is the study type. I'm going to go through this in detail over the coming 2 days. And then we have to address the sample size. How much or how many people will I need within my study in order to achieve reliable and valid results? And how am I going to sample these people out of a greater number of persons? So if I have 1,000 persons and I just want to, and I calculated the sample size of 100, how will I choose my 100 participants in a way that these 100 participants would represent the 1,000 participants that I have at the beginning from as a population? And then we talk at the end also about our data collection tools. What are we using? Are we using questionnaires? Are we using, for example, measurement tools like weights or scales? Are we doing focus group discussions? What are we using for collection of our data? So in order to achieve proper data collection, we have to choose an appropriate study design. And for study designs, we have a very important algorithm. I'm going to go through this over and over again. And this is something that has been published in the Lancet. So we have to ask ourselves the question, did the investigator assign exposure or not? And I will go through exposures and outcomes in my coming presentation. And then we have two arms. We have either observational studies or experimental studies, which are very well known as clinical trials. So I'm going to jump this slide very quickly and then move on, because I'm going to go into detail later on with what I'm going to talk about in my second presentation. Then, as I said before, we want to talk about sample size and sampling technique. I think Dr. Summer has gone through this and the tools for data collection. So for step 2, we're going to talk about sample type, sample size, and study design. Now I want you to notice something. This is very important. I want to show you. Now here, can you see all these arrows? Yes? Can you see the arrows? Yes. So the arrows are the arrows give us the flexibility of bi-direction. Very good. Thank you for that. It gives us the flexibility of going back and forth to when we are still in the planning phase of our study. So we identify a problem, we write objectives, we write hypotheses, and then we go on to the sample size and type and study design. And then we find that maybe the sample size is too big, or I will not be able to access the study population, so I need another sampling technique. Then I would need to revisit my problem and my specific objectives again and again until I find the appropriate way for me to go through my research. So these arrows being bidirectional are very important because they give me the flexibility that I need when I'm still in the planning phase of my study.
Rehab, should one first decide on the study design before calculating the sample size?
Yes, you have to do that, yes.
So should those boxes be interchanged?
Yes, yes.
Okay.
Now, we talked also about study tools and the definition of our tools and how we're going to design them, and these are also very flexible. And this is something that we, when we submit our studies to a research ethics review board, sometimes we get some comments on the study tool. So, for example, we say these questions, we get a comment from the research ethics committee saying that the questions are unclear, they're too sophisticated, this is something that not any person can answer. We may talk about, can you please add other questions like to be able to achieve your objectives. So sometimes the researchers get comments also regarding the study tools from the research ethics committees. And this is also the importance of a bidirectional arrow. Now here, when we've done the tools and we want to check if these tools are, working or not working, the procedures are working, the sample size is enough, I'll be able to access my participants or not. Sometimes I go for a pilot test where I do a mini study, very mini, like very small number, like 5 to 10 participants, and check how the study is going, how the tools are going. And based on the results of these very small sample of people, 5 to 10 persons maximum, I can go on and do major adjustments and corrections to all the steps that have preceded this point. And that's why it makes your study better, and it provides the it enhances your study tools and your ability to complete this study. Now, a very important point that the pilot tests and the results of the pilot test should never be included in the final results of your study. Now, the pilot test is just there for adjustments for the design, the objectives, the sampling technique, the tools, and you cannot use the results from the pilot testing in the results of your final study. You cannot report them.
Can I ask a question, please?
Yes, please.
About the pilot testing, how much is it a percentage from the whole sample size? How much do we assess the size of the sample?
The sample size is something that you calculate. The pilot is something that you do. So for a sample size, you have a way, and there are many ways to calculate an appropriate sample size. Many tools are available online. You can use them. I think you need, if you're not into statistics, you would need someone to help you on that. But it's very straightforward. You have your inputs. You put them on whatever tool you're using, and the sample size will be calculated, and they would say that this is the sample size that you need.
Okay, but
that's
for the pilot.
For the pilot, you don't need to do a sample size. You can just say, I need 10 to 15. It's just an arbitrary number that you say, I'm going to try it out on 10, 15 persons. I want to see how the tools are going. Let's see if people understand the questions or not. And then the results of that will help me and guide me to improve my study.
And why cannot I use them in the final assessment?
Because you have made adjustments to your study tools based on that pilot. So these results are not the results of the final study tool.
Okay.
Okay.
Thank you.
You're welcome.
So let me just add. Right. Yeah. So after the pilot testing, like if you're doing a survey study, you're going to wind up having a different survey based on the pilot testing. That's why you're doing the pilot testing. Also, in pertaining to surveys, you also want to do the pilot testing to assess for internal validity of the questions. You want to make sure that the questions are actually measuring the construct that you want to measure. And without belaboring the point, you want to, one example is that there are certain questions within a survey that are somewhat similar or dissimilar to the point where one could figure out if people are really answering similar questions somewhat in a similar way. Because if they're not, then one has to seriously think about the internal validity of the questionnaire. Also, I'm going to mention this phrase. Please don't ask me to explain it. The Cronbach alpha testing that measures the internal validity. And having said all that, this is my meager knowledge of statistics, and I always follow Rehab's advice. I always get a statistician, and there's a certain way, depending on how many questions you have, blah blah blah, that you want a certain you do want a certain number of pilot testing, and all I can say is that on one hand I take Rehab's advice and get a statistician. On the other hand, I always find myself fighting with the statistician because they're always asking me to get this huge number of pilot testing, and I'm afraid sometimes that I do so much pilot testing, I don't have I don't have any more room for a sample size anymore. But anyway, so there is a lot of steps to developing your instrument or your measuring instrument, because think about this. You know what your hypothesis is, you know what data you want to get, but you want to make sure you get good data, and hence you need to know that your measuring tool is valid.
Exactly.
And that's one of the reasons why we do this pilot testing.
Just another question. Is the pilot testing usually in the survey studies, not in clinical trials, for example? It's most probably in the survey studies, or not related?
Well, you could think of the, in clinical studies, pilot testing is actually similar to phase 1 and phase 2 testing, if you want to use that analogy. But I think perhaps the phrase pilot testing is reserved for social behavioral research.
Yes, and also if you are using just for the questions that you are asking, if you have new questions that you'd like to add to your questionnaire, you may want to pilot test these questions before you start your study. Because as Dr. Henry said, you want to know the validity or the internal validity of your questions and make sure that they are really measuring what they are supposed to be measuring.
Yeah, thank you.
Now, then we have to move on to this arrow, which is unidirectional. As soon as I'm done, I'm finished, I'm going to start collecting my data for the study. And here the arrow is unidirectional. You can't go back anymore. You will not change your design. You will not change your sample size. You will not change your objectives. You can't change the tool. You have started using the tools that you have identified. You will do quality control checks, and you will supervise the data collection. And it's as soon as you've done that, you can't go back to any of the above steps to change anything. Okay? Now, when I finish collection of my data, I should have entered my data into some sort of database, or like, for example, you could use Access or Excel to enter the data. I don't know if Dr. Summer has gone through something like that, or Dr. Zena maybe, about using the data and entering into an Excel sheet, for example.
No, we talked about types of data, types of variables, but
okay, so imagine that you have a questionnaire with 20 questions, and the 20 questions, you've asked these 20 questions to 200 participants. How are you going to analyze the data? You need to put this data onto a database so that it could be easily manipulated, and you can easily conduct the analysis that you want to do. So you would enter each row on an Excel sheet, for example, with all the variables in that row for each participant. So you'd have 200 rows, and whatever variables you have, age, sex, whatever it is, okay? You would have 20 variables because you have 20 questions. So you have 200 rows and 20 codes. You can start working on data analysis by calculating, for example, the frequency of males and females. You know how many males and how many females were in the study. You can identify the measures of central tendency, for example, the average age of participants, and so forth. So this is something that you would need to do when, after you have collected your data, you have to enter this data into a database in order to be able to analyze your data. Everyone is okay with that?
Yeah.
Yeah, super. So when summarizing and interpreting data, you can show your data as tables or graphs, or you can use statistical parameters like mean and standard deviations. And I think you've gone through that already, so we won't invest time on that. And then the last step would be interpretation of your data, which should be based on the knowledge and experience of researchers. And this part where we interpret data, we are changing data into usable and understandable information. So if I say that, for example, the body temperature of the participants that I have measured their temperature in a hospital, the average temperature was 38 degrees. Then how am I going to interpret this? I would interpret that the participants were all feverish and that I had a problem on my ward. So it's important that we are interpreting the data in a way that's understandable to people who are non-statisticians and to policymakers who may want to use this information in a way. For example, we can isolate the wards where the feverish patients are or something like that. So it has to be something that we can use. So when we conduct data presentation and statistical analysis, we would interpret and report our data. And when doing that, we would be going back to answering the objectives of our study. And this is very important because a lot of studies have specific objectives at the beginning of the study, and then they move forward, they collect their data, present their data, and then they start interpreting and reporting their data, and it has no relevance to the it's modeled out. You have to interpret and report your results in a way that is answering specific research questions and objectives. Now, a point on recommendations. Recommendations are important that they are based on the results from your research. So your recommendations should always come out of the results of your research. They are not something broad or common. They are something that has come out of your research study. So very quickly, in summary, clinical research is a very rigorous process. It always has a beginning and an end, and you need to decide on what you want to end up with. When you gather the material, you have to consider that best quality gives the best results. And so proper formulating and definition of the research topic will help you to choose the most appropriate research strategy, design the most appropriate tools, and the most appropriate analysis techniques. So we really should invest time in the research idea, the research question, the research objectives. This is where we really should invest, and also invest time in capturing our objectives and hypotheses in order to be able to conduct research, and by the end of that research come out with something useful and meaningful. And I'm going to end this presentation with a quote by Mason Cooley. Every path to a new understanding begins in confusion, and this is what happens when we start conducting any research. I'm done with my first presentation. I'd like to move on very quickly to my second presentation, because then we can have time to do a quick practical session. Is everyone okay with that?
Yeah, and let me
Yes.
just emphasize that our new Moretti participants are developing research proposals of their own to be
Yes.
presented in the next week or so. And so I think this would be a good time to take a look at what you've been thinking about and go through these systematic steps, with the first one probably being the most important. You start with the research question, not the hypothesis, and essentially the question is driven by any gaps that are out there that are existing that doesn't explain fully the phenomenon that you want to study. Because after all, I mean, that's what research is all about. You want to have, whether it's human subject research or other type of research, you essentially want to understand the world better and what are the gaps in knowledge. So that's one way to think about whether your proposal is important. And then obviously the next important step is, could you actually measure it, and also within a reasonable time frame. And so you know, think about the points in this last presentation as you think about your research proposal, and it may take several attempts to refine your research proposal. So don't think you're going to get it hit it on the nail right away. So anyway, so this is has been a very useful presentation. So thank you very much for that. So now we need to know how the heck we're going to address our study hypothesis. All right.
Okay.
Thank you.
So, thank you, Henry. Let's move on to study designs. Objectives for this this presentation. I want to be everyone to be clear about the difference between exposures and outcomes, and to identify what are confounding factors. Then we need to identify what are our types of epidemiological studies, and specifically for this presentation, we will talk about cross-sectional studies, the advantages and limitations of a cross-sectional study, and how to calculate and interpret prevalence rates and ratios. So the research design is the procedure under which a study is carried out. So the function of a research design is to ensure that the evidence obtained enables you to effectively address the research problem logically and in an unambiguous manner as possible. So this is the algorithm that I was talking about. We're going to talk a little bit about this algorithm, and we're going to invest some time on that because it's a very important algorithm. So the first question that we're going to discuss is, did the investigator assign exposure? Now we want to know what is the study exposure and what is a study outcome. So in any study, there are the primary exposure, and we may also call that the risk factor of interest. This exposure or risk factor is sometimes called the independent or the predictor variable. And then there is the outcome of interest that is also known as the dependent variable. And then there are some other intermediate exposures that may influence the outcome, and these are called confounders. Let's go through a few examples and see what these things are. So the definition of exposure and outcome depends on the question that you are asking. So the primary exposure is the one included in your hypothesis. Let's see. Now, this is a question. This is my research question. Does smoking increase the risk of lung cancer? Where is my exposure and where is my outcome? Sarah?
Smoking is factor, the independent factor, exposure, and lung cancer is the outcome or the outcome.
Okay. Yes, it's the outcome. So, what is my hypothesis here in this question?
That smoking is has an effects or may cause causation. It may cause lung cancer.
Okay, so I'm all with you except for the term causation. Okay, so yes, there is a link between smoking and lung cancer, but let's keep causation D on the shelf because we can't use it like that. Okay. So there is a relationship between smoking and lung cancer, and my hypothesis or the study hypothesis, as you rightly said, is that smoking increases the risk of lung cancer. So my exposure is smoking, my outcome is lung cancer. And both exposure and outcome, both of them are there in my question, and both of them are included in my study hypothesis. Now, for exposures and outcomes, you have to be aware that you will need to measure more than one exposure because you don't know which exposures are likely to be risk factors for the disease. You don't know which exposures are the truly primary exposures, and because some exposures may get in the way while you're trying to sort out this relationship, and these are called potential confounding factors. So this is another question. Is caffeine consumption during pregnancy associated with increased risk of low birth weight? Sausan.
Caffeine is going to be the exposure.
Yes.
And the low birth weight is going to be the outcome.
Excellent. So thank you very much. And the hypothesis, the study hypothesis would be that I am assuming that consumption of caffeine would affect the birth weight of babies. This is my hypothesis. Other possible exposures that may affect the birth weight of babies?
Smoking.
Okay, smoking. Anything else?
Infection.
Infection, maybe. Anything else?
I think when the pregnant woman, she can get like a diabetes while she's pregnant.
Yes, but diabetes would increase the birth weight. But it could, if we're talking about affection of birth weight without low birth weight, yes, diabetes is one thing. Anything else?
Preeclampsia.
Thank you. Anything else? Alcohol, maybe? Something, all these other things that you mentioned, they could be also affect birth weight. So this is my exposure, caffeine consumption during pregnancy, low birth weight is my outcome, and I'm concerned about other possible confounders like smoking, alcohol, nutritional status, hypertension, infection, whatever it is that could happen during pregnancy. Now I want you to notice something. I'm going to go to the annotation tools. I hope I can find them. Here they are, yes, okay. This is really fun. Now remember, this smoking is not included in my question, right? It's not in my research question. My research question is about caffeine exposure and low birth weight. Now smoking and anything else that I would put down there, I would consider it as a confounding factor. Now, what is a definition of a confounding factor? And this is why the arrows are so important. A confounding factor is a factor or variable that has a direct relationship with my study outcome. That's why the arrow here is a very straight arrow, okay? And has an indirect relationship with the exposure. What do I mean by an indirect exposure relationship? It could be there and it could not be there. So not everyone that drinks caffeine necessarily has to be a smoker. And so we have this wiggly arrow, okay? Everyone is okay with that?
Yes.
Yes? Super. So smoking here is a potential confounder, and I can list a lot of other confounders that I would need to address. So when I am designing my study, I have to find out where is my primary exposure, and that would be caffeine exposure. Where is my outcome? It's low birth weight. What are the potential confounders that I can think of for this study? And I have to list them all there to be able to collect data on these potential confounders when I am collecting my data in my data collection tool. So another point on exposure and outcomes is that an outcome in one study could be the exposure in another study. So I could be asking if low birth weight is associated with hypertension, and then my exposure would be low birth weight and hypertension would be my outcome. So it depends on the study question. It's very important. So this is a quiz for Golana. Golana, can you hear me? I don't think she can.
Yes.
Yeah, good. Excellent. So if I'm interested in finding out the relationship between cancer of colon and diet, what is the outcome?
What we suppose will be our outcome?
Yes, yes. Yes.
Maybe high cholesterol.
What's your study question, Golana?
What is my study question?
If I'm interested in this relationship, what could be a possible research question?
I don't know, people who are overweight are more prone to getting colon cancer.
Okay, so you're talking about people who are overweight, so they eat a lot, their diet is filled with a lot of things that maybe are not needed, and these could be the cause or the risk factor that triggers the cancer colon. Everyone is okay with that? Yes?
Yes.
Okay, super. So when I ask this question, which is the outcome, it's usually the answer is depending on the research question. It depends on what you're asking. What is your question? So if the question is how does diet affect the risk of developing cancer colon, your outcome is a cancer colon. Whereas if your question is how does having cancer colon affect diet, then your outcome would become diet. So here is a very clear demonstration of how the research question is the primary source of identification of who is my exposure and who is my outcome in my study. Now going back to my algorithm, now the first question, did the investigator assign exposure? If it's yes, there is an arm called experimental, and we will come to that later. And if the answer is no, then this is an observational study. For observational studies, you need to ask another question. Is there a comparison group or not? Now, then you have two answers. One answer is that no, we don't have a comparison group, and yes, we have a comparative group. Depending on your answer, you will have certain designs. So if you have descriptive, there are no comparative groups. Descriptive studies are concerned with and designed only to describe a situation and the distribution of variables without regard to any other hypotheses. And they answer questions related to who, where, and when. So two important descriptive studies are the case report and case series. For those of you who are in clinical practices, these are important designs. They are very simple and descriptive studies. They report new and interesting observations, and the patients are seen in a very relatively short period of time. So if I find a certain observation that I have never seen before, it's not written in the literature, there is no documentation of this before, I can report this as a case report or a case series. And the only limitation for case report and case series is that they are not a truly planned study. They just come by coincidence. Case reports are the least published in medical literature, and it's always about an observant clinician who reports unusual medical outcomes. So, and case series describe characteristics of a number of cases. In one report, they are usually between 4 to 10 cases. And the first description of HIV/AIDS was a case series study. Case series and case reports, they are useful for hypothesis generation, and their limitation is they do not have a comparison group, and so it's really impossible to make any comparisons of risk. Analytical studies, on the other hand, are studies that address the question, why are certain groups of people having a certain disease while others don't? So it's the question of why. And they provide information about the presence or absence and the strength of an association. So going back to my algorithm, if I am in this arm where I have not assigned exposure, I'm just leaving everyone to do whatever they are doing. People who smoke are smokers, people who don't smoke are non-smokers. So this is an observational study, and then presence or absence of a comparison group, this is an analytical study. I'm moving to this section of my inquiry. Direction is related to time. So if I am collecting information about exposure and outcome at the same time, this is a cross-sectional study, and I will go in depth about that. If I am starting with an exposure and following my participants forward in time, I can call this waiting for an outcome to happen. It's called a cohort study. And if I start with the outcome and go backwards, asking about exposures, this is called a case control study. Now, cross-sectional studies are classified as analytic studies if we have comparison groups, and they are also classified as descriptive studies if we do not have comparison groups. So let's see how this goes. So cross-sectional studies collect information about exposure and outcome simultaneously. So they ask the question of what is happening now, and they are sometimes termed as snapshot studies. They are also called frequency studies or prevalence studies because the measure that we calculate out of cross-sectional studies is the prevalence of the disease. So, for example, if we examine the presence of absence of the disease and the presence of absence of exposure to a risk factor at the single point of time, this is a cross-sectional study. So what's a prevalence? Does anyone know what a prevalence is? Dua?
The prevalence is how much is the spread of any disease or anything.
Excellent. So it's about how many people have the disease at any point in
Yeah.
time. Very good. Excellent. At any point in time. So prevalence is usually termed the magnitude of the problem. How many people have something, whatever that something is. So prevalence of an outcome is measured without reference to exposure. Like, for example, if I want to know the percent of students who scored grades of A+ in the final exams. Or I could be interested in the prevalence of exposure. So I could measure the percent of students who have attendance rates more than 75%. So it could be about exposure or the prevalence of outcome depending on what I'm looking for. And I can get them both out of a cross-sectional study. So in a cross-sectional study, all the indicators that come out of the study designs are equations. So I hope you're all comfortable with basic math. So prevalence is actually a proportion. In my numerator, I have the number of cases of a disease diagnosed during a cross-sectional study. And my denominator would be all the examined individuals in the study, and I could multiply by 100 to get a percent.
Excuse me, I'd like to ask, can I use the term prevalence in our studies when it's related to the population prevalence, and in the study we use the term frequency?
Yes, in population studies, prevalence is very well used. If you're using a very small study and your sample size is very small, this would be a frequency or a proportion within the study. You cannot identify it as a true prevalence because it's not the whole population. But for cross-sectional study, we're going to say that this is the prevalence in this study. Okay. It's actually a frequency proportion, okay?
Yeah.
Because it's not a representative sample of the whole population. Okay.
Yeah. Okay.
Yeah. So let me show you how the design of a cross-sectional descriptive study would look like. So if this is my population and I am taking a representative sample, if I'm not using the whole population. Of course, it would be all the more better if I can use the whole population, but it's very time consuming and it's actually impossible to include all the population in a study. So we usually use a representative sample. Using this representative sample from my population, or the condition, and without the disease and the condition, and then I can calculate the prevalence of the disease or the condition in this representative sample. Where is my numerator and where is my denominator? Sayed, I haven't heard from you a lot for a long time.
Yeah.
Yes. Number of, where is in the prevalence of disease and condition? Where is my numerator?
Numerator is a number with disease or condition.
Excellent. Where is my denominator?
The number of all cases, all included cases.
All persons included. So it's actually this people with the disease and people without. Both of them are in my denominator. Excellent. Now, as you see, time here, this is time and it's now. This is about this point in time, okay? Because in my other studies tomorrow, you will see the time is going backwards or forwards depending on which direction I'm using. In an analytic study, I would have 4 groups of people. I would have people with disease and with exposure, people without the disease but with the exposure, people with the disease without the exposure, and people without the disease and without the exposure. And then I would have, how many prevalence proportions would I have? Maha?
Can I have the question again?
If I have 4 groups, how many prevalence proportions would I get?
I guess it will be related to the exposure.
Yes.
So I will have two.
Two prevalences. Excellent. I have the prevalence of the disease among the exposed and the prevalence of the disease in the unexposed group. Excellent.
Yes.
Thank you for that. So, in cross-sectional studies, we are interested in a possible relationship between serum cholesterol level as my exposure and the ECG evidence of coronary heart disease is my outcome, and I collect information about exposure and outcome simultaneously. The results of my study would look like this 2x2 table. Now, I'd like to spend a few minutes on this table because you're going to see this table all the time with me. So, in any study, we have our 2x2 table. This is the disease status. We have people with the disease and people without the disease. And the totals would be the total of A plus C, all people with the disease status, and people without the disease would be the B plus D total. The exposure status is about exposure. So we have people who are exposed and people who are not exposed. The first row is the exposed, the total is A plus B, and the unexposed is the C plus D, and this is the grand total, A plus B plus B plus C plus D. Now you have to have a correct design of your table in order to be able to calculate any indicators from any study. So you have to have the yes in the disease outcome here, and the yes for the exposure here, so that you get the A, B, C, D in the correct place. The cells A, B, C, D are in the correct place. And then we can calculate whatever we want to calculate using the table in this design. Okay? Now, this is the results of the study that I was talking about. The relationship between serum cholesterol as the exposure and the ECG evidence of coronary heart disease. These are the results of my study. So, can you, any of you, please tell me, how many people in the study have coronary heart disease?
150.
Excellent, thank you very much. And how many people are exposed? How many are exposed to high cholesterol, ya جماعة? Sarah. Sarah is out.
500.
500.
Yeah.
500. Excellent. Perfect. Perfect. So as you see, this is high cholesterol. We have 100 participants with coronary heart disease and 400 without, and all of them have high cholesterol levels. And those with normal or low cholesterol levels, we have 50 with coronary heart disease and 450 without. And this is my 2x2 table. So what is the prevalence of exposure to high cholesterol? What is the prevalence of coronary heart disease among those with high cholesterol level?
Uh, 100 out of the 500.
Excellent. Thank you so much, Sarah. Yes. So we have 100 participants. This is the prevalence of coronary heart disease among those with high cholesterol level. 100 over 500. Thank you. And what is the prevalence of coronary heart disease among those who are unexposed to high cholesterol levels?
50 out of 500.
Excellent. Thank you, Sausan. So this is disease in the exposed group and prevalence of coronary heart disease in the unexposed group. And if we have the numbers, we have 100 over 500 and 50 over 500. and inshallah. So the prevalence ratio, I was talking about the prevalence ratio, and we would divide the prevalence ratio by the prevalence in the exposed over the prevalence in the unexposed, and we would get an answer of 2. Now, it's not about math as important as the interpretation of what this value means out of the study. So in interpreting this value, what the prevalence ratio of 2, we can interpret this as saying that the prevalence of coronary heart disease is 2 times higher among those with high cholesterol compared to the prevalence of in those with normal or low cholesterol. What does that mean? How can this answer our study hypothesis?
That exposure to high cholesterol would double the risk of getting coronary heart disease.
Thank you so much. Thank you. Thank you so much. Okay, now advantages of cross-sectional studies is that we can determine the prevalence of diseases, we can determine exposures to risk factors, and we can study a connection between exposures and disease. Cross-sectional studies are really quick and economic, and they study distribution of diseases, and they can set priority for diseases control. So from a policy perspective, cross-sectional studies are very important for priority setting, and they are also useful to generate hypotheses and service planning. The main limitation is that we can only calculate prevalence, and we can never calculate an incidence in cross-sectional studies. I will talk about incidence tomorrow when I talk about cohort studies. The time since exposure to risk factor and disease occurrence is not known. Both the outcome and the exposure are assessed at the same time, and so there is no temporal relationship that is evident from a cross-sectional study, and so we cannot really use them to establish relationships. A major limitation is the chicken and egg dilemma, where you don't know what started first. Did the exposure lead to the outcome, or did the outcome lead to the other way around? So, for example, if I have a researcher that wants to study a relationship between cardiomegaly and hypertension, that researcher surveyed a representative sample of men above the age of 40 and sorted them out as those with cardiomegaly without. And then he asked them to measure hypertension. He found that the prevalence of hypertension is higher among those with cardiomegaly, but did he know which one came first? It's very difficult and it's impossible to do that. Did cardiomegaly lead to hypertension, or did hypertension lead to cardiomegaly? This is something that can never be determined using a cross-sectional study. I'm done with my presentations.
Doctor, can I have a question, please?
Yes, please.
Can you go back to the last slide about the cardiomegaly and hypertension?
Oh, yes, one moment. Here you go. Yes.
Yeah, as far as I know, the term cardiomegaly means like enlarged heart, right?
Yes. Yes.
Okay. So if you wanna have study the relationship between them, it's not back and forth ones, because I feel like there is a lot of exposures can lead to the cardiomegaly. Do I understand that well? Like not only hypertension is the only reason, like can be the high cholesterol.
Yes. There are many reasons for cardiomegaly. But if I'm interested in the question, does hypertension cardiomegaly, then the best design is not cross-sectional study. And you will find this out tomorrow. Yani tomorrow, let's address your question tomorrow when I talk about cohort studies. Okay, because hypertension, if I talk about hypertension and cardiomegaly, I want to have a link between them that have exposure to hypertension can lead to cardiomegaly. This is not the best design because you don't know which one started before the other. Okay? Thousand?
Yeah, I lost the connection for a minute. Yeah, I'm so sorry.
Okay, no problem. So, are you okay with this, or can we revisit this question tomorrow, please? Okay.
Yeah, totally. Yeah.
Cohort studies, and then we'll revisit this question again. But don't forget, you have to remind me. Okay.
Okay, I will. Thank you.
Good. Super. Okay. Henry, can we do a breakout room, or what should we do now? Maha, can you please tell us what your group has agreed on for the first question?
So for the first problem, research question, which is the more effective drug in controlling hypertension? Drug
Okay.
A or B?
Okay. Thank you.
We added the null hypothesis too.
Yes.
That there is no difference between drug A and B in controlling hypertension.
Okay, excellent. Thank you.
Dr. Sasha, you can share
your objectives, please. Yamaha.
Okay. Objective is to compare the effect of drug A and B in lowering the blood pressure among hypertensive patients, and to compare the compliance of patients to drug A and drug B.
Excellent.
For research design, it could be experimental because we are going to start with giving drug A and drug B, or it could be observational cohort if we get some patients taking drug A and some patients taking drug B. So we didn't give the drug; we just observe them.
Okay, if you're going to address the second objective, which is about compliance, then it can be an observational cohort. But if you're going to compare effectiveness, it has to be an experimental study. This is maybe we can revisit the design again after tomorrow, because then it will be very clear which is which when I finish the presentations about.
Yeah, Dr. Tamer said the same thing. Same thing.
Perhaps you could determine compliance in the experimental study.
Yes, you can if you want to, but I mean, if they said that they can do it as an observational cohort, you cannot compare effectiveness of drugs in an observational cohort.
Right, sure, okay, agreed.
Okay.
All right. What did the other group say?
Thank you, Maha. Please stop sharing and let Sausan share her first slide.
Sure. Go ahead, Dr. Sausan.
Okay, give her time. All right.
Okay.
Hey, can you see it?
Yes. Can you unmute yourself, Sausan?
Yes, okay.
Okay.
So our research question was, is drug B more effective than drug A in controlling hypertension?
Okay.
Can you hear me?
Yes.
Can everybody hear me?
Yes.
Yes.
Okay. So for the research question, is drug B more effective than drug A in controlling hypertension? And that's why we based on it. The objective is to determine the effectiveness of drug A comparing to drug B. And that's led us to deciding that it's analytical and experimental.
Okay. So anyone from the other group has any comments on that?
Yeah. Same.
Okay. Okay. So Sausan, you have the screen. Please move to the problem, second problem.
Oh, wait a second. I have some comments.
Okay. Yeah.
Go back to the
Yes.
slide.
First slide. Yes. Mm-hmm.
All right. In using in following SMART objectives, I don't like the word controlling.
Okay.
Okay. I mean, essentially.
Why? Why not?
Well, because it's not very specific to me. I think what you want to do is measure blood pressure.
Okay.
I think that's more specific than controlling.
Okay. Okay.
So it's more of a ambiguous word.
Okay.
And the research question almost looks like, in fact, it does look like an objective. I mean, the question is, is there a better drug to treat hypertension than existing standard of care, or something like that? But research question and research objective looks too similar.
Yes, you're right. But usually the objective يعني, can come out of the research question.
Oh yeah, absolutely. But that doesn't. I mean, but it's again, it looks more like an objective than a question. Just you know, maybe a difference in style. And my last comment. What's the difference between effectiveness and efficacy?
Would you want to who will answer this question?
Yes, right. Who will answer this question? I'm not picking on people.
Okay.
I'm looking for volunteers.
Okay.
Can you repeat the question again? What's the difference between efficacy and what?
And effectiveness. Why did you use the word effectiveness as opposed to efficacy? There is a difference between the two words in the scientific literature.
Yes.
I think maybe efficacy means like you might be like going toward a certain result, or by being biased to a certain result, as far as I know what the meaning of efficacy.
No, efficacy looks at the physiologic effects of the drug, whereas effectiveness takes in things like whether people are actually taking the drug either because of side effects or compliance issues. So again, the issue is how generalizable is this study going to be to the study population? And there, I mean, this is just a study just looking at the physiologic effects of the drug, unless you also look at compliance. But in the real world, you want to look at issues like access to the drug, compliance issue, and acceptability of the drug. You know, a lot of people on anti-hypertensive may not take the drug because of effects on sexuality and other side effects. So all of that brings in issues about effectiveness. Will it be effective in the community for whatever reason? But for sure, I mean, in a study, you just looking at efficacy. Now, having said that, there is a branch of science called implementation research, where you actually want to see how you could implement the results of your study. But anyway, I'm taking this to another level. But I just wanted to point out the word effectiveness. So anyway, that's enough for me. Carry on.
Okay. Thank you. Sausa?
Yeah, for the next problem, residents in the slum areas have unsatisfactory living conditions. There is no information about the prevalence of TB in the slum areas. So our question was, what is the prevalence of TB between the residents of the slum areas? And for our objective, we said that we need to measure the prevalence of TB in an unsatisfactory living condition, which refer to the slum areas. We consider this an observational design, and it's going to be very descriptive since we're not comparing these residents with other residents or anything else. And in the same time, we consider it a cross-section.
Okay. Anyone has any comments on this slide? Okay, Maha, please Sausan stop sharing, and then Maha can share. Okay.
For a research question, it was, is TB a problem in slum areas? And the null hypothesis was unsatisfactory living condition has no effect on TB prevalence. Objective to measure the prevalence of TB in slum areas, and it's the same, observational descriptive cross-sectional study.
Okay. Any comments on that?
Is there a difference if we mention slum areas versus unsatisfactory condition, or it's the same?
Well, I think it's yani, if we're going to be yani, we can say slum areas and we can say unsatisfactory living conditions. It's yani, more or less the same, but in the objective, I think we have to be very specific about where we want to yani, to identify our place or where we're going. Yeah.
So better to mention slum areas.
Yes.
I have a comment actually about the research question. I think just because it said in the problem there is no information about the prevalence of TB in the slum areas, that doesn't mean it might be really a problem. We just don't have enough information about it or no information. So I don't think you can ask, is TB a problem? Because it's already a problem, but we don't have enough information to prove this problem, as far as I understood.
Well, what is meant by a problem?
Excuse me, can you repeat that again?
What does one mean by a problem?
You mean it's not measurable?
Well, I have no idea what the problem is. I even before I start thinking about measuring it, well, having you mention it, how does one measure a problem? I have many problems in my life. I don't want to bore you with the details, but I have no idea how to measure problems. All I'm saying is too ambiguous.
Yeah, the problem could be that TB is present or not, or causing complication or not.
Oh yeah, causing respiratory problems.
Yes, yes.
right? You know, cause inciting riots. I don't know. This may be a problem for the officials in slum areas. Could be that.
So better to ask what is the prevalence.
Or something similar.
I agree.
You could say, what is the magnitude of TB among residents in slum areas?
Right.
But again, the magnitude is about the number of cases or the complication detected.
It's when we say magnitude, it's usually another term to say that we're looking for prevalence. Yes.
Should I share the next one?
Yes, please.
So the problem of coronary heart is increasing. And we want to study the relation to dyslipidemia. So the research question is dyslipidemia a risk for coronary heart disease? And the null hypothesis will be dyslipidemia has no effect on risk of coronary heart disease. For the objective to assess the association between dyslipidemia and coronary heart disease, research design could be case control or cross-sectional analytic.
Okay, very good. I have no objection, but it can also be a cohort study if we have the time and the resources, but that's fine. We haven't gone over cohort studies, so that's fine. Anyone has any comments on this? Okay, let's have some share, please. Thank you.
Should I share my screen?
Yes, please, Salsa.
Yeah, the internet connection is really bad. Okay, I'm sorry. Okay, for the research problem number 3 to 59 years old men, there is evidence that dyslipidemia. So our risk question was, is dyslipidemia associated or linked or related to the increased risk of CHD? I think we can add here to among men.
You can, yes, you can if you want to, yes. Yeah.
Yeah, because it was so specific to the men, to the certain age in men. Okay, and the research objective was to discover the correlation between the dyslipidemia and the increased risk of the CHD. And since it's observational of the 35 to 59 years old men, we consider it observational, and there is no comparison group, and in the same time analytical. And in prospective way, not a retrospective way, because it takes a lot of time to develop the CHD.
Yes, but then we would use another. We would not go for a prospective. We would use a retrospective. Yeah, prospective here, we have it. Yeah, and you have put it down, but it's contradictory to your last statement. If it takes a long time for coronary heart disease to develop, then a prospective design is not favorable because it's too time consuming.
Yeah, I'm sorry, I get confused between them.
It's okay,
I'm
we'll
trying
do
to
that
catch up. I'm sorry.
We'll do it tomorrow, don't worry. Okay,
thank you.
Any questions? Anything? Any additions on this or comments on what this group has presented?
Well,
No, I
well,
just want to go ahead.
I see in the research question the word associated. In the objective, I see the word correlation.
Yes.
Could you comment on the distinction, if any, between those two words?
You want me to comment?
Yeah, or
Okay.
anybody else, but why? Well, whichever group was associated with that slide, which word do you mean?
So,
does it make a difference?
No, there is a huge difference between them, and but I didn't want to interfere with the group's decision on writing up. Correlation is a very specific term that's used in statistical analysis between quantitative variables, and association is more about identifying the presence or absence of a risk. يعني to measure the risk, whether you're measuring the odds ratio or the relative risk, whatever that is. So there are two very distinct terms, and I can discuss further, but it's going to take quite some time, and we haven't still covered enough ground to identify what association really means, and I don't know if Samar has discussed correlation or not.
No. Well, let me ask a follow-up question. Is determining a correlation one way to determine whether two items are associated?
It's
This a question to all of us?
It's one way.
Well,
if the
I'm not having a private conversation, so
yeah.
I mean,
it's one way of identifying this association.
Okay, so association is a more general term.
Yes, and correlation, the how strong the correlation is depending on the value of the correlation coefficient would give us this strength of association.
Okay.
Can I ask you a question?
Yes.
Hey, listen, guys, you don't have to ask if you could ask a question. Just go ahead and ask it already.
Okay.
We don't have a lot of time here.
Okay.
We're a small group.
I'm not sure, but is associated mean that it mean increase the risk, but correlation could be positive or negative. So two variables could be correlated, but one preventing the other, not causing it. Is this the difference between?
No.
Correlation mean positive correlation mean that the risk factor causing the disease?
Correlation is you have to understand correlation from a statistical point of view, which is that it measures the relation between two quantitative variables. So, for example, we can say this is very generic. This has nothing to do with the slides. So we can say there is a correlation between the height or height of babies and their age, for example. So as the baby grows, the baby's height or length will increase. Okay, so this is a positive correlation. We can have a negative correlation is by مثلا exposure to sunlight and influenza infection. So the more sunlight we're exposed to, the less influenza we get, for example. So it's something like that. But a positive or negative association does not mean that this association is absent or present. These are two different things.
So there is positive and negative association too, not just correlation.
Yeah. If I say that there is no association, then there is no risk. So, and then you would get an odds ratio or a relative risk of 1. So, and that I'll go through this tomorrow, inshallah. But so there is no association, then there is no risk factor, and what we assumed could be a risk factor is not there. The study has shown that there is no risk from this exposure on this outcome. You got my point?
I'm going to say something more.
Yes, sure.
So if we're talking about the difference between association and correlation, so what's the difference between association and linkage and relation?
If we say that something is related to the other, يعني زي ما from the questions we can say that this exposure is linked or related to this outcome. And that's why we measure the association. Is there an association? Is there a link? Is the exposure related to this outcome? Okay. Now, a very important point that a lot of you have raised during the discussions was that this exposure is a cause for this outcome. And this is something that we cannot, precisely state something like causation. This exposure causes this outcome, because in epidemiology, for any statement to reach a level of causation, we have to fulfill the Bradford-Hill's criteria of causation, and that's a long story. So, just take my word for it. We cannot say that this exposure will lead 100% to this outcome. We can't do that. But we can say that this exposure is associated with this outcome, with a certain level of certainty and with a certain magnitude. So depending on the value of the relative risk or the odds ratio, we can determine the strength of this association.
Yeah, I got it. Thank you.
Okay, you're welcome. Henry, do you want to add something to this?
No, not from my point of view.
Okay.
Okay, very good.
Tamer is here. He can help.
Tamer's keeping quiet.
I don't know why.
I think he's away.
Okay.
Yeah.
So
that's okay. All right. Well, any final questions?
One more problem. Who's sharing? Towson?
One more problem. Right.
Yes. Towson,
sorry, I had a phone call. So that what you're looking for me?
No, we weren't looking for you.
I had a phone call. Sorry for that.
It's okay. All right. Last problem.
Okay. Last problem. Yes. Towson.
Okay. So yeah, the problem. Can you hear me? Okay. The problem with endometrial.
Hey, that's another thing. Stop saying.
Can you hear me?
Could you hear me? Okay. Enough. All right. You'll know soon enough if we can't hear you. Okay. All right. Go ahead.
Okay.
And we hear you.
The problem was okay. The problem with endometrial cancer is increasing due to the wide use of HRT. So the research question was: is HRT responsible for the increase of the endometrial cancer?
Yes.
Yeah. Is it responsible for the increase of it or not? For our objective, we thought that we're gonna measure the association, not the correlation, the association between the usage of HRT and the development, I'm sorry, I didn't write it right, and the development of the endometrial cancer.
Endometrial cancer.
Right?
Yes.
Yeah. And of course, that was for our research design, it was observational and analytical. Observational and analytical, but in a backward design, because it takes a lot of time to develop the therapy for the cancer.
The cancer. Okay. Anyone has any comments on this group's presentation on this slide? Okay.
So now, in the previous study, the objective was to determine the correlation, and now I'm seeing the word association. I'm just totally confused. Why use correlation? I mean, unless the study design, in one study design, you're measuring correlation, and in the next one, you're is association a statistical concept? I'm just asking why the use of two different words in the objective?
The same for the same study?
No,
for a different study?
Does a different study warrant a change in the word we use?
You can use whatever you want. There is nothing black and white, but I mean, to put correlation in the objective is very specific. It will really tie your hands behind your back when you analyze your study.
I'm just asking the group, why was correlation used in one study and the word association used in the other study? That's all I'm asking. Is there a rhyme or reason?
Is it right?
That's all I'm asking. And I don't know. We could keep on thinking about it.
Correlation is when there is relationship one by one.
All I'm asking is, why did this group use the word correlation in one study and association in the next study? That's all. Very simple question.
I think they should be. I think there should be both association.
Okay.
Okay.
What about your comrades? What do they think?
I think there is a difference between correlation and association. Like for the case study, like we have the research problem, it's really has here in evidence that the dyslipidemia, it's really associated with the increased risk. So he's having already a solid evidence that he can state that. So there is already, even if it's a weak correlation, there is correlation. But in the problem here, he's already saying it's increasing for that. So it's like 100% correlation, 100% solid evidence that it's increasing due to that, not other things. And that's why we used here association, not correlation. As far as I understood from Dr. Rehab, which was really, really good. Okay.
All right, why don't we move on? I'm not entirely convinced, but that's okay.
Okay. يلا يا مه.
So for our group, we use association in all the problems, okay?
Okay.
For the research question, does hormonal replacement therapy increase endometrial cancer? Objective to assess the association between hormonal replacement therapy and endometrial cancer. We'll use observational analytical case control study. Cohort is available in theoretical level because it would take long time to get the results.
Okay, super. Very good. Any questions from the other group on this group's presentation for this problem? Okay.
Maybe I suggest some revision in the research question, because in this implies causation. So maybe increase the risk, or maybe I will suggest adding increase the risk of endometrial cancer.
Okay. Okay. Very good.
This is particularly because we use a retrospective study in the research design.
Okay, super. Anything else?
I think the way that we use association or correlation based on the problem or the research question that we're asking for. So the way that the research problem 3 asks different question than the research problem 4.
Okay, but correlation is a very statistical term. To use correlation in the objective is something that will make it you have any objective in any study. These are the points or the objective that you have decided that your results will answer these objectives. So if for any reason you couldn't collect the data in an appropriate manner, or you couldn't do the correlation analysis in a manner that is accepted for any reason, then that objective that has the word correlation in it would be an objective that you cannot achieve. So that's why it's better to stay away from statistical terms, especially when you are writing down your objectives, because you can later on, when you do the analysis, achieve your objectives, and then using whatever analysis you decide to do, correlation or others, and write it up in a manner that will answer that specific objective. This is from my point of view. Henry?
Yeah, no, I agree with that, especially if you're presenting to me.
Okay.
Okay.
Tamer, are you there?
أيوة, yes.
ما تقول لنا حاجة.
it was my pleasure to join you today as usual. كل مرة بنسمعك بنتعلم منك زيادة Thank you very much.
Thank you, Tamer. But there was a huge discussion about correlation and association, and I think you
actually
the to answer that.
correlation. Yes, you usually, as you said, it's two terms, statistical distinction between them. When we use a correlation, usually we use the statistics of correlation Pearson or Spearman correlation to look for a correlation coefficient. However, the association can be measured using the chi-square test or even another test, which could be a t-test or whatever. So this is the discrepancy that may arise from using the two terms, association or correlation. And if it is possible to not to put it in our objective, unless you are totally sure that this is what you are going to do, correlation using Spearman or Pearson correlation statistically, or association using the suitable test of significance, it will be better. Otherwise, I think it's okay to use association or correlation. Linguistically, they are not different.
Okay, thank you so much for that.
Well, let's for the interest of time, I'm just Googling all of this. And let me, at this point, just share one link about an article that talks about association, correlation, and throws in another word, causation. So why don't you look at that article and any other article you want to look at, and we will have a special session one day this week on association, correlation, causation, and any other word you want to throw in the mix. How's that?
Super.
Okay. All right. Okay. Anyway, this has been great. A lot of as you in conjunction with the slide you put up previously, what did you say? Research serves to confuse us or something like that?
No, any path starts with confusion.
I see. Okay. Well, we're ending with confusion, and
Yes.
but we'll clear it up tomorrow. Okay.
Inshallah. Yes.
All right. Hey, so this has been great. Rehab, thank you very much. Tamara,
Thank you.
thank you very
Thank
much.
you. Thank you very much.
This has been wonderful, and so everybody have a good rest of the evening. And tomorrow we'll talk about. Last week we talked about how important informed consent is, and tomorrow we talk about when we could actually not get informed consent for studies. Okay. And we'll talk about minimal risk, and then Rehab will continue with her trilogy. Okay, very good. Okay.
Thank you.
All right. Have a good evening, guys.
Have a nice evening.
Thank you.
Take care.
Thank you.
Have a nice
Okay.
evening.
Thank you.